This is Marjan. I'm a third year pulmonary critical care fellow here at Montefiore. And today I'll be giving a talk on lung ultrasound for the diagnosis and management of acute respiratory failure. So let's get started. So I have no disclosures. This talk will follow a recent state-of-the-art review that we published in the Lung Journal this past December. The objectives of the talk will be threefold. One, to review the basic foundational sonographic signs that define specific respiratory conditions that cause acute respiratory failure. Two, to appraise the current literature supporting the use of lung ultrasound in the diagnosis of these conditions. And three, to review the evidence of lung ultrasound in the continued management of patients with acute respiratory failure. So to start, a thorough understanding of the thoracic anatomy is necessary to properly apply lung ultrasound. Here on the top left of the screen, we see a cross-section of the anatomy of the chest wall. If we were to place a probe between two rib spaces, we can identify the visceral pleura of the lung interfacing with the parietal pleura. In the absence of any pathology, the visceral and parietal pleura, with the aid of a thin layer of pleural fluid, slide against each other with respiration, and this finding is what we call lung sliding. If you look at the video here, you can clearly see that there is sliding, this hyperechoic line, the pleural line. We see this to and fro shimmering, which we call lung sliding. Just as we can auscultate any portion of the thorax, we can apply lung ultrasound to any region of the chest wall. There are many protocols published that are validated on how exactly to scan the lungs, but for this talk, and really in the context of evaluation for undifferentiated acute respiratory failure, a rapid sequence that was initially described by Lichtenstein, known as the Blue Protocol, is most appropriate. This is the Blue Protocol, which stands for Bedside Lung Ultrasound in Emergency, and it involves examination of 4 interspaces on each hemithorax, so a total of 8 points, but 4 per hemithorax. So point 1 is at the mid-clavicular line of the second intercostal space. Point 2 is the anterior axillary line, right along the 5th intercostal space. Point 3 is along the mid-axillary line. And point 4, which Lichtenstein termed as the PLAPS point, PLAPS standing for posterior lateral alveolar pleural syndrome point, is located in the posterior diaphragm. And to really get it properly, you have to tilt the transducer slightly anteriorly. And this is a very important point, and it's aptly named because this really is a part of the lung that on ultrasound you want to evaluate for consolidations and what he calls alveolar pleural syndrome. So to validate, we'll go over the paper that in which he published the Blue Protocol, but just briefly, in a study of 260 patients with acute dyspnea that presented to the intensive care unit, evaluation of these 4 points per hemithorax, and of course identifying and interpreting specific sonographic findings at each point led to a correct diagnosis of acute respiratory failure in over 90% of cases. So this is table 1 from our review, where we summarize what we refer to as the foundational sonographic signs of lung ultrasound. And they comprise the pleural line, A lines, B lines, alveolar consolidation, and pleural effusion. Recognizing each of these signs, along with interpretation of specific features that are associated with each of them, can allow intensivists to employ lung ultrasound in the rapid diagnosis and therapeutic management of acute respiratory failure. And there's now robust data to support its use, which we'll go over. So let's go ahead and review each of these signs and the key features that are associated with each of them that can help us narrow a differential diagnosis for acute respiratory failure. So let's start with the pleural line. So here we see the same video from earlier, but here focusing in, we see the curvilinear hyperechoic pleural line that's just beneath the chest wall and between 2 rib spaces. Here I'm actually just identifying 1 rib space, but there's another one on the other side. So we should really learn to appreciate what a normal pleural line looks like because the absence of a normal pleural line is very important in us identifying pathology. So normal pleural line is thin, it's contiguous, meaning it's one line there, it's not fragmented or broken. There's a nice to and fro shimmering of the visceral and parietal pleura sliding against each other. And here on the right, we use M mode, which is motion mode, uh, through the pleura. And over time, we see this granular artifact is generated from the lung beneath the pleural line. And this granular artifact is what we call the seashore sign, which indicates a normal lung. Now here we see the absence of lung sliding, the absence of that granular artifact beneath the lung. And instead, on the M mode screen, we see horizontal lines beneath the pleural line, what we denote as the barcode sign. In the ultrasound image here, we see that there's no pleural sliding, and the movement is really just contraction of the chest wall muscles, but no real movement of the lung. So while highly sensitive for pneumothorax, this finding can also be seen in pleurodesis, which is where either through chemical or mechanical means, the visceral and parietal pleura fuse together, so there's no lung sliding. Or we can also see this in significant hyperinflation where there's very reduced lung sliding, such as in a COPD exacerbation with hyperinflation air trapping. And this can be seen particularly in the anterior apex region of the chest wall where there is more reduced lung sliding than the other parts of the lung. So highly sensitive for pneumothorax, but not 100% specific. What is 100% specific is what we're seeing here, which is lung point. So here we're seeing really the contact point between aerated lung sliding in and the air collection that defines the pneumothorax over here on the right. And on a CAT scan, this arrow is pointing at the exact point that this ultrasound is visualizing. And on M mode, we're seeing that if we were to cut through this point, we can see the alternation between the seashore sign and the barcode sign really being 100% specific for pneumothorax. Of course, it's not 100% sensitive though, because we have to find this. And in certain situations of, for example, a very large pneumothorax where air fully encapsulates the entire lung, no lung point would be seen. In situations where there is reduced lung sliding, lung pulse is something that can be identified. And lung pulse is characterized by the synchronous beating of the pleural line with the cardiac cycle. And this too rules out pneumothorax. So here on M mode, we see this vibration, this synchronous beating of the pleura with each heartbeat. And here we're seeing it on lung ultrasound B mode. So I actually recently employed this just a few days ago. We had a patient in the MICU who had a sudden cardiac arrest. It was a COVID patient with severe ARDS, and he happened to be paralyzed. And there was such reduced lung sliding from the severe ARDS that I wasn't fully convinced that I saw lung sliding. So I actually dropped the patient's respiratory rate down to 0, and I was able to identify lung pulse, the sequential beating of the pleura with a heart rate that was vigorously beating at over 100 beats per minute, and it ruled out pneumothorax. So it can be employed in certain situations. So continuing on with the pleural line, in inflammatory conditions like ARDS, interstitial lung disease, or pneumonia, the pleural line can be altered and altered in a way that it appears thickened and fragmented in appearance. So here we see two videos really showing similar things. The image on the right is a little bit worse. We see a very thickened pleura. We see this subpleural consolidation here just juxtaposed to this irregular pleural line. There's this inflammatory exudate that thickens the pleura and also reduces the lateral sliding of the pleural line with respiration. So, identifying the pleural line to be abnormal can tell us a lot about, or at least is very sensitive to disease, and really the etiology for what exactly is this subpleural consolidation or this irregular line is dependent on a lot of different factors, but ultrasound is very sensitive for picking up that something is abnormal with the pleural line. Moving on from the pleural line, let's talk about A lines, which are defined as these horizontal hyperechoic lines that are equidistant from the pleural line and each other. Presence of A lines signify a high gas to volume ratio, so well aerated lung. But in the context of acute respiratory failure, just seeing A lines doesn't mean that the lungs are completely normal. It could mean that there's significant airways disease, such as asthma or COPD. It could represent pulmonary embolism, vascular disease, where we don't see, in the absence of a pulmonary infarction, we could still see acute respiratory failure from a pulmonary vascular disease point of view. We could see A lines with pneumothorax, but really would have to interrogate the pleural line to determine that whether a pneumothorax is present by lung sliding and lung pulse. The next foundational sonographic sign is the B line. So here we see a CAT scan and a drawing of anatomy, and really beneath the visceral pleura are these secondary pulmonary lobules, which are separated by these interlobular septa, which are also actually connected to the visceral pleura. And, early on in my career, I thought that, B lines just represented pulmonary edema, but really anything that widens the interlobular septa, whether it's fluid that's hydrostatic or due to increased permeability, whether there's an inflammatory process or scarring, collagen deposition, any of these things would allow propagation of ultrasound waves, creating artifacts that we call B lines. And here we see the ultrasound image of the B lines, and they are these well-defined hyperechoic comic tails that extend from the pleural line all the way past the edge of the screen. And they also erase intercepting A lines. There is something called a Z line, which kind of looks like a B line. I don't have an image here, but it looks like a B line, but it doesn't extend to the edge of the screen. And it's thought that these Z lines may be just trapped fluid beneath the pleural line, but they don't really have any clinical significance that we know of. And here on the CAT scan, we see, prominent interstitial markings, septal widening, which on ultrasound would look like these diffuse B lines. So up to 2 B lines per field may be normal, while 3 or more represents a B pattern. Another term for it in the literature is alveolar interstitial syndrome. So if you were to concurrently evaluate the pleural line with B lines, it can help define the etiology. So, cardiogenic pulmonary edema is really a condition that is a hydrostatic nature. And, unless it's an acute, highly inflammatory cardiogenic pulmonary edema, you would see a normal continuous pleural line with normal lung sliding and diffuse bilateral B lines. As we can see here in the context of B lines representing cardiogenic pulmonary edema, that increasingly coalescent B lines represent increasing severity of pulmonary congestion. Contrast that with what we're seeing here, which are also B lines, but really a pleura that's highly inflammatory, thickened, reduced with a subpleural consolidation. It's clearly different from the pleural line with B lines we just saw, and this finding can be seen with ARDS, interstitial lung disease, or infectious pneumonia. Moving on to the next sonographic sign is the consolidated lung. So here we're seeing 2 large consolidations, and really lung consolidation forms when alveoli collapse or become fluid-filled, and this process allows for ultrasound waves to propagate through lung and visualize a real image versus artifacts like A lines or B lines. Features that are typical of consolidation include a tissue-like pattern that we're seeing here, loss of a pleural line, and air bronchograms. So on the left-hand side, we see these white speckles, and these white speckles actually represent trapped air within a consolidation. These white speckles are the air bronchograms. They're linear, punctiform, and hyperechogenic. And if you were to compare the 2 videos, we see that on the left-hand side, the air bronchograms are static compared to those on the right, which are dynamic. And the dynamic behavior is associated with infectious pneumonia. And really here is a beautiful image here. We see that with respiration, and independent of the lung really moving as a whole, we're seeing that these air bronchograms are dynamic and moving independently within the airway. And it's believed that these are here because the airway is sufficiently patent to allow air to move through this airway along a consolidated lung. Contrast that with a static air bronchogram, which is believed to be due to resorptive atelectasis. As a result, there is loss of lung volume due to hypoinflation, and the air bronchograms reflect residual trapped bronchial gas that's within the consolidation. And we'll review the literature later on, why exactly is dynamic air bronchograms associated with pneumonia and static air bronchograms not. So the last foundational sign that we'll take a look at is the pleural effusion. Simple pleural effusions are completely anechoic spaces, and importantly, to define it, it has to be surrounded by the chest wall up here, the diaphragm to the right, and the consolidated lung on the left. And here at the very top on the static image, we see a anechoic space representing a simple pleural effusion that's typically a transudate, though simple appearing effusions can always be exudates as well. Contrast that with these images here. These are complex pleural effusions. They can be more varied. They can demonstrate varying degrees of echogenicity. Here on this image, we see floating debris, the plankton sign. We can see here complex septations that can represent a pneumonic effusion or empyema. And here we see also another image of the plankton sign, this floating debris, and a layering with increased dependency, causing increased echogenicity at the base relative to a non-dependent region. And this can be suggestive of a hemothorax. We call this the hematocrit sign, as blood we know is layers when in the more dependent regions. So to bring everything together, this was figure 2 from our paper, which is a proposed algorithm for the systematic diagnostic approach to acute respiratory failure using lung ultrasound. So we suggest that following the blue protocol that we examined points 1 and 2 to begin with, which is, if you remember, the second intercostal space and the fifth intercostal space on the anterior chest. And just to quickly go through, with A lines, if we were to identify A lines, the next step would be to look for lung sliding. With no lung sliding, with lung point would diagnose pneumothorax. No lung sliding could represent pneumothorax or COPD. If we were to see lung sliding, it could be COPD or asthma. Lung sliding in the context of a DVT would suggest pulmonary embolism. Lung sliding with the context of a subpleural consolidation with DVT would suggest PE with a pulmonary infarct. If we were to see B lines, if we were to see that it's focal, subpleural with subpleural consolidation, it could be a pneumonia. Focal could also just be pneumonia without a subpleural consolidation if it's an early pneumonia. B lines that are diffuse could be multifocal pneumonia, or with a normal pleura, normal lung sliding could be cardiogenic pulmonary edema. If we see diffuse B lines with irregular thickened pleura and reduced sliding, it could be ARDS. If we were to see subpleural consolidations, taking a look at points 3 and 4, if we were to see static air bronchograms and pleural effusion, it could be ARDS or pneumonia. Dynamic air bronchograms would favor pneumonia, but certainly static air bronchograms can also be part of pneumonia. So, these lung ultrasound findings are highly sensitive, but really the specificity for any diagnosis comes with marrying the clinical context. But certainly following this algorithm can really help you hone in on certain diagnoses rapidly in the context of acute respiratory failure. So now we'll move to appraising the literature, looking at how lung ultrasound performs in diagnosing these respiratory failure conditions. So there's now robust data for lung ultrasound's capability for diagnosing pneumothorax, cardiogenic pulmonary edema, ARDS, pneumonia, and pulmonary embolism. And these are the conditions that we'll go through. So we'll start here with pneumothorax. This was a large meta-analysis from 2011 that compared lung ultrasound against chest X-ray. And it found across the board that lung ultrasound had a significantly higher um, sensitivity at 88% um, compared to 52% for chest X-ray, with similar specificity of 99% and 100% against chest X-ray. So much more sensitive than chest X-ray for diagnosing pneumothorax, whereas it's fairly similarly specific. Of course, this hinges on the fact that you're appropriately using the ultrasound, mapping out at different areas of the lung that you suspect would have air. So, the apex or the anterior chest if a patient's laying flat. This was a study that looked at 140 ER physicians who were asked to identify on B mode clips, which is the normal ultrasound images versus M mode, with corresponding M mode images of the pleural line. And what they found was in a subgroup analysis of ER providers that had less than 250 scans versus ER providers that had greater than 250 scans, that using M mode increased the accuracy from 88% to 94%, increasing specificity as well from 87% to 97% using B mode alone. So if you're inexperienced and you're trying to identify pneumothorax with lung ultrasound, using M mode really improves your accuracy, sensitivity, and specificity. But if you're a fairly experienced ultrasonographer, using M mode didn't really add very much. Moving on to B lines. So a common question when faced with diffuse B lines in acute respiratory failure is whether the etiology of the B lines is inflammatory from a condition that causes increased permeability like ARDS or pneumonia, or if the B lines are hydrostatic in nature from cardiogenic pulmonary edema. This was a small study of about 58 consecutive patients who presented with respiratory failure with diffuse B lines. And the authors characterized the pleural line, and they found that pleural line abnormalities, reduction of lung sliding, having spared areas where it's not homogeneously affected. There are areas that are that have these subpleural consolidations, whereas other areas are spared. All of these were highly specific for acute lung injury ARDS versus a cardiogenic pulmonary edema etiology. This was a study that was built from the previous study of 43 subjects that were prospectively enrolled to evaluate if M mode could be utilized to differentiate the cause of B lines, namely, again, cardiogenic versus non-cardiogenic pulmonary edema. So the authors determined the final diagnosis of non-cardiogenic pulmonary edema, cardiogenic pulmonary edema, and normal lung by reviewing the history, physical exam, and chart review. And they divided their cohort of 43 subjects into these three groups. So we'll take a look at these three patterns that the authors found using M mode. So the first pattern here, we see that there's a continuous pleural line and a horizontal subpleural pattern that are interrupted by these cardiac pulsations. So again, when we see horizontal subpleural pattern, we think the barcode sign with pneumothorax. But here we're seeing that with interruption of the cardiac pulsation, this is kind of like a lung pulse finding that this is normal lung. This next pattern here, we see again a continuous pleural line with a vertical subpleural pattern. And then these last two images show the same thing, just different degrees of severity. We see a very fragmented pleural line with vertical subpleural pattern. Again, fragmented pleural line, vertical subpleural pattern. And combining the pleural and subpleural patterns, the authors found that a fragmented pleural line with a vertical subpleural pattern was highly suggestive of a non-cardiogenic cause of the B lines. A continuous pleural line with a vertical subpleural pattern was more suggestive of a cardiogenic pattern for the B lines, cardiogenic pulmonary edema. Continuous pleural line with a horizontal subpleural pattern was control group, which is all healthy. So, using M mode, interrogating the pleural line and the subpleural pattern can kind of help guide sonographers, intensivists, as to what is the etiology of the pulmonary edema, the B lines, cardiogenic or non-cardiogenic. This was a meta-analysis that compared the diagnostic accuracy of lung ultrasound against chest X-ray in a cohort of patients suspicious for decompensated heart failure. So it was a very large study. The meta-analysis, it comprised of almost 2,000 patients, adult patients who underwent lung ultrasound and chest X-ray, and consistently lung ultrasound outperformed chest X-ray with a pooled sensitivity of 88% compared to 73% with similar specificity. Lung ultrasound also had a higher positive likelihood ratio with a very narrow confidence interval compared to chest X-ray, which had a 7.36 positive likelihood ratio, but you see the confidence interval is quite large. The final diagnosis of acute decompensated heart failure was made by a clinical expert who reviewed the clinical chart, echocardiography, and pro-BNP. This was another study, a randomized trial that compared lung ultrasound with clinical assessment versus a combination of chest X-ray and pro-BNP with clinical assessment. Essentially, this was a study, hitting lung ultrasound versus chest X-ray and pro-BNP, which was better. Both had a clinical assessment component. So after an initial evaluation of 518 patients who presented with acute dyspnea in a cohort of suspected heart failure exacerbation, we see that lung ultrasound combined with clinical assessment outperformed the chest X-ray plus pro-BNP with clinical assessment with a much higher accuracy. The area under the curve for the lung ultrasound assessment was 95% versus just 87% for the pro-BNP arm. Moving on, so this was a study looking at lung ultrasound for predicting pulmonary capillary wedge pressure. This involved 102 consecutive patients who were mechanically ventilated, all of whom who underwent pulmonary artery catheterization. Lung ultrasound was used to evaluate for the presence of A lines and B lines. So using a cutoff of 13 here and a cutoff of 18 here, the authors were able to report that an A-line predominance had a greater than 90% specificity, but a 50% sensitivity for a pulmonary artery occlusion pressure to be less than 13 and less than 18. However, they saw that a B-line predominance was seen across a wide range of pulmonary artery occlusion pressure. So really, if we were to see an A-line predominant pattern, it was highly specific to have a low pulmonary artery wedge pressure, but having B-line predominance, you couldn't really make a call on what the wedge pressure would be. So now let's move on to how ultrasound performs for pneumonia. So the dynamic air bronchogram published in 2009 by Lichtenstein. So this was a prospective study of 68 mechanically ventilated patients, all of whom who underwent bronchoscopy for evaluation of a alveolar consolidation. So 52 patients were clinically diagnosed with pneumonia. These patients were found to have a patent airway with a positive bacterial culture on bronchoscopy. And 16 patients were diagnosed with atelectasis, and they defined this as patients who had a blocked airway with a negative bacterial culture. So the authors found that the presence of dynamic air bronchograms were seen in 62% of cases of pneumonia versus just 6% of cases in atelectasis. Compare that with static air bronchograms, which were found in 38% of cases of pneumonia versus 94% of cases of atelectasis. So this led to a conclusion that dynamic air bronchograms had a specificity of 94% and a sensitivity of 61% for pneumonia, with a positive predictive value of 97% and a negative predictive value of 43%. So take-home point here from this study was dynamic air bronchograms highly specific for pneumonia, but you can still have pneumonia with static air bronchograms. This was a systematic review looking at a number of studies with different designs, looking at the accuracy of lung ultrasound for the diagnosis of ventilator-associated pneumonia. This first study, ZAGLI, it was a study involving 221 ventilated patients with clinical evidence of pneumonia, clinical evidence being infiltrate on chest x-ray, clinical signs like fever, secretions, leukocytosis, and a positive EA quant, which is essentially a tracheal aspirate that was positive. In these cases where there were clinical evidence of pneumonia, they found that the presence of consolidation by lung ultrasound had a sensitivity and specificity of 59% and 84% for pneumonia compared to controls who had none of these features, no infiltrate, no clinical signs, no tracheal aspirate. The second study, Burlett et al., this was a purely sonographic study, and in a cohort of 57 patients who were ventilated, they found that the presence of consolidations, namely dynamic air bronchograms or fluid air bronchograms, held a sensitivity of 92% and a specificity of 65% for diagnosing VAP. This was another study recently published in 2016. This was a multi-center prospective study of 99 patients with suspected ventilator-associated pneumonia, where lung ultrasound was used in combination with microbiologic culture data to diagnose VAP. So there are a lot of graphs and tables on this paper, but I highlighted the most important findings. And that was for the diagnosis of ventilator-associated pneumonia, the authors found that two or more air bronchograms produced a specificity of 97% and a positive predictive value of 94% and a positive likelihood ratio of 7.1 for VAP. But we see that the sensitivity is only 22%. Subpleural consolidations greater than or equal to 1 and dynamic air bronchograms greater than or equal to 1 also had pretty high specificity, positive predictive value, but again, low sensitivity. What they did was they used a combination of findings, ultrasound plus clinical evidence. So if you were to look here, this V plus and EA gram, these are unfamiliar terms to us, but V plus is really a VAP lung ultrasound score, and EA gram is just endotracheal aspirate gram stain. So if we were to see evidence of pneumonia on lung ultrasound with a gram stain, we see that that combination led to the highest area under the curve for diagnosing VAP. Contrast that with just the blue over here, just lung ultrasound, both of which outperformed the CPIS, which is the clinical pulmonary infection score, which is a combination of things we look at, vitals, leukocytosis, things like that. Lung ultrasound outperformed the CPIS either alone or CPIS with a positive gram stain, which I thought was pretty remarkable. This was a prospective study of 124 patients with suspected VAP, where lower respiratory tract cultures were obtained along with procalcitonin. So the authors found that a positive lung ultrasound, which they defined as presence of subpleural consolidations, lobar consolidations with dynamic or static air bronchograms, plus a procalcitonin of greater than 0.25 to have a sensitivity and specificity of 81% and 86% for VAP. And we see that, lung ultrasound plus procal outperformed white blood cell count alone, procal alone, CRP alone, CPIS score alone. Moving on to PE. So this was a prospective study of 357 patients with suspected PE. Suspected PE being defined as a well score of greater than 4 or a positive D-dimer. These patients underwent a multi-organ ultrasonography scan, which was considered diagnostic for PE if they identified subpleural consolidations like this as a pulmonary infarct RV dilatation on echo, or DVT on compression leg ultrasonography. So this was a multi-organ ultrasound looking at legs, lungs, and the heart. All of these patients underwent CT pulmonary angiography. So we see that in patients with suspected PE, evidence of pulmonary infarction, which they found at 30% roughly at the bases, had a sensitivity of 61% and a specificity of 96% for PE. Similar specificities were found with echo and compression ultrasound, but really the beauty of this comes together if you use multi-organ ultrasound, because the sensitivity shoots up from 60% all the way up to 90%. So combination of heart, lung, and leg with lung ultrasound, echo, and compression ultrasonography shot the sensitivity up to 90% with a specificity of 96% for pulmonary embolism. So, you know, the CTPA was really done as a confirmatory study, but lung ultrasound diagnosed PE pretty well as well. So this was the study that generated the blue protocol I referenced earlier. Published in 2008 in 260 consecutive patients who presented with dyspnea to the ICU. 21 patients were diagnosed with PE by CTPA. And the authors found that a normal, with lung sliding, with an A profile, with a venous analysis of thrombosed vein, that PE was diagnosed with a sensitivity of 81% and a specificity of 99% in this cohort of 260 patients who presented with dyspnea to the ICU. If you want to look at the paper for the other diagnoses, he has the data there for pneumothorax, pneumonia, pulmonary edema, etc. So this was table 2 from our review, where we summarized the pooled sensitivities and specificities for lung ultrasound compared to chest radiography for the acute causes of respiratory failure that we just reviewed. We see that lung ultrasound consistently outperforms chest radiography in a number of pooled analyses for each condition. So now we'll move on to the last section of the talk, which is lung ultrasound to facilitate clinical decision-making in patients with acute respiratory failure. So this was a review on lung ultrasound to confirm real-time endotracheal tube placement. So I'll start the video here, and here we see the trachea, vocal cords, and here we see, I'll pause it real quick just to orient us. On the ultrasound image, we see that right here in the center, this is the trachea. And if you focus here as I play the video, this is where the esophagus, findings of an esophageal intubation is. So let me go ahead and play it. So here we see the tracheal ring. And then here, if you focus in, the person is doing an esophageal intubation. And right as the esophagus is being intubated, we see that a second air mucosal interface forms on the image right here. Now the person pulls the ET tube back and puts it right through the vocal cords. And here we see, we don't see a second air mucosal interface. We see a slight change in the trachea, confirming that the intubation was successful. So with ultrasound, a meta-analysis was performed on almost 17,000 patients, and 550 of those, 33%, were identified as esophageal intubations. And looking at the data, the authors are able to find that ultrasound identified esophageal intubations with a pooled sensitivity of 93% and a specificity of 97%. So I don't think ultrasound will replace, capnography, but it can certainly be used as an adjunct if you have it. So moving on from ultrasound use in intubations, the ability of lung ultrasound to rapidly evaluate for the development or resolution of B lines as a surrogate for extravascular lung water is something that people have looked at. And this is a study looking at its ability to identify B lines to guide fluid administration during the initial resuscitation period in sepsis. So in a prospective observational study of 32 patients with septic shock and ARDS. Um, this study used a lung ultrasound score, which is a different protocol, which scores degree of pulmonary congestion using lung ultrasound across 16 points of the thorax. And we see here that after a liter of fluid was bolused, the lung ultrasound score rose slightly. And then 40 minutes later, after fluid loading, it continued to rise. Compare that with the PF ratio during fluid bolusing. We see that after the fluid was bolused, the PF ratio went up, but then it went back down. So really what this is showing that lung ultrasound may be more sensitive for detecting pulmonary congestion than non-invasive monitoring for hypoxemia. After fluid bolusing, the lung ultrasound score suggested that there was congestion that persisted despite the PF ratio that went back down after fluid loading. Here, I'm just showing the titles of two separate papers. This first paper, ultrasound assessment for extravascular lung water in patients undergoing dialysis, time course for resolution. So this paper demonstrates that over time, the degree of B lines decreased during dialysis, and really just demonstrating that ultrasound can be used to assess real-time changes in extravascular lung water. And here they can monitor dialysis, clearing the pulmonary edema from volume overload in dialysis patients. This title down here is a protocol that Lichtenstein developed, which is the FALS protocol, which stands for Fluid Administration Limited by Lung Ultrasound, which essentially just suggests that the interval development of B lines during fluid resuscitation should caution clinicians to withhold further fluid bolusing during shock. We all have our grievances with the 30 cc's per kg, but for shock, but if you were to incorporate lung ultrasound during that period, it would really caution you on when exactly you're getting to the danger point of resuscitation with volume. Assessment of B lines have also been looked at as a role for weaning off mechanical ventilation. So this was a prospective study looking at the development of anterior B lines during 62 SBTs, each of which were lasting 1 hour. So we see in red are the SBT failures and blue is SBT success. Failure they defined as SBT was interrupted by clinical intolerance or need for reintubation after extubation. And we see that SBT failed in 33 cases, and weaning-induced pulmonary edema, WIPO, occurred in 17 patients, all of whom failed SBT. The authors found that the development of 6 or more B lines during the SBT diagnosed weaning-induced pulmonary edema with pretty high sensitivity and specificity. In the 16 cases that failed and weaning-induced pulmonary edema did not develop, the reason for failure was attributed to either neurologic deficits or critical illness, myopathy. So these are just some other trials that looked at prospective studies that found that interval development of pulmonary congestion by lung ultrasound during SBTs failed to predict or predicted failed SBTs or post-extubation distress. So without going through all the papers, just to show you that there's other literature that showed these findings. So let's move on now to using lung ultrasound for recruitment of alveolar consolidation. So what we're seeing here, a really neat video of the essentially the sonographic sign of intrapulmonary shunt. So a consolidated lobe may have variable impact on oxygenation, and this variable impact is dependent on the degree of pulmonary shunt and whether hypoxic vasoconstriction is effectively occurring. We've all seen patients with large consolidations, but they're just breathing on room air without any distress. And then we're seeing another patient with that same consolidation in acute hypoxemic respiratory failure. And why is that? Well, it may be that the degree of shunting that's occurring between the patients is explaining this clinical difference in using lung ultrasound, we may be able to identify with color Doppler these pulmonary vessels. So really here we're seeing complete perfusion with no ventilation. And of course, we can open the lung with bronchoscopy, recruitment maneuvers, PEEP increases, or we can redirect perfusion with positioning nitric oxide, decreasing PEEP, all to help improve and restore the VQ mismatch that's occurring. So here, this was just a short case that was published looking at real-time tidal recruitment of lung ultrasound. So we know that one form of ventilator-induced lung injury is atelectic trauma, and here we see evidence of alveoli that's recruiting with tidal volume delivery and then de-recruiting at the end. We see right here recruitment with restoration of the consolidation, and here the consolidation appears again. And here, following a PEEP titration adjustment, we see that there's no more consolidation. And at the bottom here is a video of alveoli opening and closing cyclically, atelectic trauma in real life. So this is a prospective observational study of 10 consecutive patients who were intubated with ARDS. We see that in these graphs that as the PEEP was increased, the non-aerated lung volume decreased, the PF ratio increased, and here are the sonographic images of the consolidation area decreasing with PEEP titrations. Of course, we know that simply increasing PEEP does not always mean recruitment. Interrogation of compliance curves, looking at the stress index, assessment of the RV, all need to be factored in to titrate PEEP judiciously and effectively. But this just shows that lung ultrasound can be used as an adjunct to kind of monitor for recruitment and use it concurrently with the other factors so that we could recruit safely and effectively. So here is a video of real-time recruitment using lung ultrasound. I'll just play this. We see these dynamic air bronchograms suggesting that air is going into this consolidated lung, likely a large pneumonia. And then a recruitment maneuver is sustained for 40 centimeters of water for 40 seconds. And as we see that during the recruitment maneuver, this consolidation is turning into beelines in real time, showing real-time recruitment of alveoli. Up here is a video that's playing. Here, I'll just kind of rewind here. We see, atelectic trauma alveoli collapsing at the end of ventilation. And then if we were to move a little forward, we see that with a PEEP of 5, there's less alveoli that's recruiting. Moving ahead with a PEEP of 10, even less that's de-recruiting. PEEP of 15, even less. And then here at the end, PEEP of 20, we see that all the alveoli are open and remain open at the end of the tidal volume delivery with increased positive and expiratory pressure. So here is an algorithm that was proposed by Tussman et al. In 2016 in performing a recruitment maneuver with real-time ultrasound. So I'll just kind of go through the algorithm. So the first step is, evaluating evidence of lung collapse. We see that yes, there's lung collapse here. If there is not, then just continue lung protective ventilation. The next step would be to check hemodynamics. We know that increasing PEEP will reduce preload, can cause stress on the RV, all of which need to be monitored, and you have to ensure that there is stable hemodynamics. And then in step 3, this is where we really get into the recruitment part. So we're using a stepwise increment increase in airway pressure, and real-time ultrasound is used to detect a plateau pressure, at which point dependent lung collapse disappears. This is the top circle here, defined as the opening pressure, at which point we see that the lung collapse is no longer there. And then a stepwise decrement in PEEP is performed until the ultrasound identifies the start of lung recollapse in the most dependent pulmonary areas. This is the closing pressure, denoted by the lower circle. And at the end, the PEEP is chosen to be 2 centimeters above this closing pressure to help maintain alveoli that stay open. If anyone wants to look at this protocol more closely, here's the citation. So now we'll conclude. We'll conclude now by looking at the diaphragm, which has been looked at as a marker for critical illness and a barrier for successful ventilator liberation. So on the left, we see a normal diaphragm. We see that it's, as it contracts, it's displacing the liver caudally. Compare that to the right, where, with inspiration, the diaphragm is barely moving, the liver is barely being displaced. So just you can visualize and get a sense of how weak or strong the diaphragm is. But beyond visualization, you can also measure it. So this was a prospective study on 210 healthy adults to determine reference values for diaphragmatic motion on M mode. So we see that if we use M mode here to cut across this portion of the diaphragm, over time we see that as the diaphragm moves up, we see that you can measure the diaphragm excursion. And you see that there are different values in men and women as it relates to normal, quiet breathing, voluntary sniffing, or deep breathing, where the displacement can be 7 centimeters in men and 5.7 centimeters in women. Beyond the excursion, there's also diaphragm thickening that people look at. So here we're looking at diaphragm thickening with respiration, and this is viewed at the zone of apposition, which is right here where the diaphragm and the pleural line kind of interface. And here we see on this video that this is the diaphragm, and we see that it's thickening with respiration. This hyperechoic line in the middle of this muscle, the diaphragm muscle, is the phrenic nerve. And just like we measure the IVC with max minus min, you can also calculate the thickening fraction here with the diaphragm thickening at inspiration minus expiration divided by expiration. And here on M mode, we see that this is where the diaphragm is thinnest, and here we see the diaphragm is thickest, and you can determine the percentage of thickening fraction during respiration. So, while the sonographic definition of diaphragm dysfunction is variable, they have done other studies where they found that these measurements, thickening fraction and thickness, they significantly correlate with endotracheal pressure during phrenic nerve stimulation. And this suggests that they strongly associate with diaphragm strength. So there have been 2 large meta-analyses looking at diaphragm assessment on ultrasound, and using proposed cutoff ranges of 10 to 15 millimeters for diaphragmatic excursion and between 20 to 30, greater than 20 to 30 for thickening fraction to predict extubation success. These 2 meta-analyses found a pooled sensitivity and specificity of about 70 to 80% for successful extubation. But the authors of these meta-analyses cautioned that a lot of the studies were very heterogeneous in the timing of diaphragm measurement, whether they were done during spontaneous breathing or during full mechanical ventilatory support. And the definitions of extubation failure was also varied, so it's very hard to draw conclusions from these studies. This was probably the best study done looking at diaphragm assessment. So this was a recent study in 2019, a prospective multi-center trial looking at 191 mechanically ventilated patients who were at high risk for extubation failure. High risk defined as intubated for more than 7 days, greater than 65 years old, and also they had comorbid cardiopulmonary disease. And ultrasound was used to assess for diaphragmatic dysfunction, which they defined as excursion of less than 10 millimeters or thickening fraction less than 30%. And this assessment was performed, importantly, following a successful SVT. So all these patients passed a successful SVT, the diaphragm was measured, and they found that there was no difference in either parameter, thickening fraction or excursion, to predict successful extubation. So we see here on the right and on the left, excursion and thickening, there's no difference in patients that succeeded or failed. So the conclusion that the authors came to was that diaphragmatic dysfunction may still be useful in identifying mechanisms of SVT failure. But after a successful SVT, diaphragm assessment wouldn't really add much to clinical decision making regarding whether or not to proceed with ventilation. So if a patient fails an SVT, it may be worthwhile to check the diaphragm. But if a patient succeeds, then really looking at the diaphragm wouldn't really add much. So, wrapping up here, limitations of lung ultrasound. So, of course, like any application of point of care ultrasound, a lung ultrasound is operator dependent and requires years of training and practice to achieve mastery. I harped on this a little earlier, but really, when a patient presents with acute respiratory failure, clinicians must be able to not only acquire and interpret images rapidly, they must also be able to integrate these ultrasound findings with the clinical scenario. Over and over again, we found that lung ultrasound is highly, highly sensitive to a lot of different things, but really the specificity for any one condition comes when we marry the clinical picture and the scenario together with the ultrasound findings. Also, while studies have consistently the studies that we reviewed have consistently reported favorably on the accuracy of lung ultrasound. All the studies were performed by expert sonographers, and the investigations may have been prone to bias brought on by lack of complete blinding of the ultrasonographer, and there may have been integration of other clinical data that we didn't really see along with the disease prevalence in the study cohorts. So there is a lot of limitations in the studies that we reviewed, but overall, though, I think there is a pretty strong signal for a lung ultrasound to be very applicable in acute respiratory failure. So to conclude now, I'll just read the conclusion that we wrote in our paper. The current era has seen lung ultrasound emerge as a well-validated modality for the diagnosis and therapeutic management of patients with acute respiratory failure. Lung ultrasound can be applied at the bedside in an immediate and repeated manner to help critically ill patients. While a powerful tool, the importance of provider input for integrating sonographic findings within clinical context is critical for the effective and judicious use of lung ultrasound. We believe that lung ultrasound is an indispensable tool for diagnosing and managing respiratory conditions and should be a core competency for critical care providers caring for patients with acute respiratory failure.